Management options for vesicoureteric reflux. First is watchful waiting or observation. In these cases, sterile urine and good bladder emptying are essential. It's about prophylactic antibiotics, behavioral recommendations, and probiotics, what's called suppressive therapy. Second is endoscopic surgery. Many different injectables are present, like deflux. Third is the open repair. It's classified according to the approach to the ureter: suprahiatal, infrahiatal, intravesical, extravesical, or combined. Antibiotics that are commonly used for prophylaxis of reflux are as follows: trimethoprim and amoxicillin in infants less than 2 months, as the liver of the infant cannot clear the sulfa. In more than 2 months of age, Septrin or trimethoprim sulfamethoxazone and nitrofurantoin can be used. Medical management of reflux. Continuous low dose of prophylactic antibiotics until resolution of the reflux. Suspension of the oral dose at third or fourth standard therapeutic dose. Amoxicillin and ampicillin recommended for children up to 6 weeks of age. No trimethoprim sulfamethoxazone prior to 6 weeks of age, as it will cause kernicterus. Nitrofurantoin is best suited to minimize fecal resistance, but cannot be used prior to 2 months. Bladder retraining, improved toilet hygiene and bladder emptying, timed voiding, double voiding, and proper perineal wiping. Timed voiding meaning voiding at regular intervals. Double voiding in the same session to confirm the voiding by a double voiding. Elimination of constipation, anticholinergic therapy if needed for bladder dysfunction, periodic urine culture every 3 months, yearly radiological studies, serial DIMSA scan if recurrent attacks of pyelonephritis with scarring suspected, no need for confirmatory voiding cystourethrogram even if reflux returns, as it's usually not clinically significant. The landmark studies that have validated watchful waiting for reflux. The International Reflux Study in children, kids less than 9 years of age were included with high grade of reflux, with randomized watchful waiting and corrective open surgery. Surgery was more effective than prophylaxis in reducing but not eliminating the occurrence of pyelonephritis, incidence of UTIs about 40%, and decrease in renal scarring, same in both groups. Untreated voiding dysfunction associated with more UTIs and persistent reflux. Birmingham reflux study was on 104 kids randomized to medical and surgical management of high-grade reflux. Incidence of scars were the same in both groups. Indications to treat adult reflux: non-obstructive flank pain, febrile UTIs, pyelonephritis, and before pregnancy. Surgical management. There are indications for cystoscopy prior to surgery. First, non-visualization of entire urethra on VCUG. Second, inconclusive radiographic definition of lower urinary tract or upper urinary tract anatomy. Third, uncertainty in urethral location or anomaly. Fourth, localization of Hutch diverticulum. Fifth, suspected active infection. There are indications for anti-reflux surgery. First is the scars. Second, high-grade reflux, grade 4 or 5, with evidence of scarring. Third, associated with congenital abnormalities of the vesicoureteric junction. Fourth, renal compromisation as failure in renal growth or worsening of the function. Fifth, persistent reflux in girls at puberty. Sixth, breakthrough UTIs despite prophylactic antibiotics. And seventh, non-compliance with medical treatment. There are principles for surgical correction of reflux. First, to exclude the secondary reflux. Always consider bladder function preoperatively. Adequate mobilization of distal ureter without tincture or devascularization, and the creation of submucosal tunnel with preserving the Paquin ratio 5:1. Attention to anatomic detail to prevent stenosis, angulation, twisting. It's achieved by carefully by caring for the entry point, which is the hiatus, and the direction of submucosal tunnel, and in the end the ureteromucosal anastomosis, which will be the new orifice. Attention to muscular backing of the ureter to achieve anti-reflux mechanism. Inadequate backing will cause failure. Gentle handling of the bladder to reduce post-operative hematuria. Approaches for ureteric reimplantation. There is an intravesical approach, extravesical, and combined. The intravesical approach, first the polytanolate bitter, which is described as suprahiatal tunnel. Glenn Anderson, which is described as infrahiatal tunnel. The Cohen operation, which is described as cross-trigonal reimplantation. Extravesical techniques as Lesch-Gregoire. It's contraindicated in presence of Hutch diverticulum, and it's not recommended for bilateral cases, and we will explain later why. Combined techniques as Paquin technique, which involves extravesical approach to the ureter and intravesical approach, which is polytanolate bitter. Success rate in low-grade reflux is about 100%, while for high-grade reflux is about 90 to 95%. Post-operative evaluation after reflux open surgery is as follows. First, you must continue the antibiotic therapy until confirmation of resolution. Second, in cases of low-grade reflux, ultrasound at 6 to 12 weeks, no post-operative voiding cystourethrogram unless there is dysfunctional voiding, post-operative hydronephrosis, or urinary tract infection. In cases of high-grade reflux, ultrasound and voiding cystourethrogram at 3 months. About the techniques, the polytanolate bitter technique, there's a comparison here is a comparison between the intravesical techniques. The polytanolate bitter is about forming a new tunnel which is suprahiatal, so the ureteral orifice is the same, while in Glenn Anderson the hiatus remains the same, but there is new inferior orifice. In Cohen, the hiatus is the same, but the new orifice is new, superior, and contralateral. There are the advantages and disadvantages for each technique. For polytanolate bitter, the advantage is long tunnel, but it has a chance of kinking of the ureter. While in Glenn Anderson, we avoid the kinking of the ureter, but it has limited tunnel length and difficult distal anastomosis as we reach near the bladder neck. In Cohen, there are multiple advantages. Long tunnel without difficult anastomosis, good for small bladders and thick walled bladders. It rarely gets kinked or obstructed, and it's also good with bladder neck reconstruction indicated in cases and works for bilateral cases. Disadvantage that it's hard to recannulate the orifice again, and it's a major issue in countries where urolithasis is endemic. About the extravesical approach and combined approach, advantages and disadvantages, the classic Lesch-Gregoire technique is easy and has a stable submucosal tunnel with good length. But there is transient urinary retention which might be seen in up to 20% of cases due to neurologic damage to nerves around the distal ureter. Combined approach as Paquin has a stable tunnel, long tunnel, ideal for dilated ureters and complex redos. Complications of ureteral reimplantation. There are earlier complications, there are late complications. Early complication, first, there is persistent reflux. It usually resolves and it's more common with high-grade reflux, and it's not actually a real complication. Contralateral reflux. It's more common with high-grade reflux and correction of reflux in duplex system. Synchronous but missed contralateral reflux. Sometimes you correct one reflux on one side and you miss the other side. And most of them resolve. And there is no need for prophylactic reimplantation for unilateral reflux. There is no such case as bilateral reimplantation in cases of unilateral reflux. Just saying for protection or prophylaxis for the other side. If less than 5 years of age, it needs to restart the prophylactic antibiotics. Obstruction. Early obstruction is a mild degree and is normal post-operative. But acute obstruction is likely due to kinking, twisting, intramural blood clot, or extramural compression by submucosal hematoma or edema. It may need temporary double J stent or nephrostomy tube and usually resolves with time. Urine retention, which may be seen in Legg-Gregg-Barr, bleeding, and infection. Complication. The late complication can be classified into obstruction and recurrent or persistent reflux. Obstruction occurs at different locations. Suprahiatal may be due to kinking or ischemia, as peritoneal letter. Hiatal. The hiatus is too lateral or anterior, leading to high reimplantation phenomena. When bladder is full, it resolves spontaneously, needs stenting or reimplantation at some times. Obstruction at the level of the tunnel, more common with neurogenic bladder or posterior urethral valve, where it's hard to make smooth submucosal tunnel in the bladder. Balloon dilatation or stenting is an option. It might need reimplantation as well. Obstruction at the level of the orifice, ischemic stenosis or poor technique. Recommendation is dilatation and stenting, endoscopic unroofing if tunnel is long enough, as this may disturb the Pacman ratio. Recurrence or persistent reflux. It's very rare for low-grade reflux. It's usually due to inadequate length to urethral diameter, which is Pacman ratio 5:1, or poor muscular backing, which are the factors that support the anti-reflux mechanism. It can also be due to failure to recognize secondary reflux from the beginning, either due to posterior urethral valve or neurogenic bladder. And this is the main, this is in many cases, this will be noted. We need to address these issues before reimplantation. Post-operative retention after Legg-Gregg-Barr technique occurs in 20% of cases. It's usually only transient and relieved by Foley-catheter or continuous intermittent catheterization for 1 to 2 weeks. It happens in cases of bilateral reimplantation in boys in less than 3 years of age, in patients with previous voiding dysfunction, and patients with high-grade reflux. Causes of failure, which meaning persistent reflux after the correction surgery. It's either due to technical failure to recognize secondary causes of reflux, scarred ureter, or VUR fistula, vesicoureteric fistula. Technical failure, meaning failure to provide adequate packing, which is the most common, or failure to achieve the Pacman ratio, the length to urethral diameter ratio, or failure to taper the dilated ureter in cases of large ureters. Failure to recognize the second causes of reflux as posterior urethral valve or neurogenic bladder or voiding dysfunction. Causes of long-term obstruction following reimplantation can be summarized in ischemia, angulation at hiatus, inadvertent passage of ureter through peritoneum or viscera, compromise at hiatus or within adequately developed tunnel.